So we will try to put this together and send this out early next week, aiming for Monday, but maybe Monday in another time zone. We have taken through, and I've tried to group our discussions into major categories. I think the first one was opened up by Dr. Fenter, focusing on the fact that we really need to reframe the question around the 90s. And he said actually this applies for all three 90s and adding the caveat of early. So looking at what percentage of the people that we test actually also have the CD4 count greater than 500. And so recommending the 90% of people living with HIV who know their status early. The second two major policy issues that were raised up were linking to home-based testing. There seems to be almost universal endorsement that this is an underutilized opportunity that we really should scale going forward. There was also general support for exploring self-testing, recognizing that we don't really have a lot of evidence, but that shouldn't stop us from trying to collect that evidence now. Three other related policy issues that came up were getting permission from South African government with regards to counselors allowed to do at-birth PCR in the labor wards, recognizing that it being a nurse-driven activity might limit its scale-up. Need to really understand around incentivizing, I'll talk about that later, and also the opportunity of putting pressure for establishing the unique patient identifier. In terms of PEPFAR rules, I think the one big thing that came out was looking to see, can we use PEPFAR money to include the non-communicable disease screening as part of our HTC package? In terms of priorities for South African government at the national, at the provincial, at the district level, looking at putting counselors back in the facility. That if we want to reap the facility-based yield, there need to be lay counselors who are there. And at the same time, there should be also consideration taken for dedicated space in the facilities for counseling and testing. Definitely a move towards less data and less data capture driven data and looking at the technology that is available to help us manage our information. There were some proposals around specifically the facility-based targeting the visitors to people who are visiting people in the wards, and really looking at strengthening the linkages between the Department of Correctional Services and the Department of Health for prisoners who are being released from prison. And I think the other cross-cutting thing for South African government was around these various community-based HIV counseling and testing modalities that are being supported by PEPFAR-funded partners now. What happens post-2017 to the continuity? Private sector, there were two major issues that we spoke about with the private sector. How do we incentivize private practitioners to play their role? And then very specifically, how do we get the employers to play their role in support of the 90 targets, getting them to commit to 90% of their employees tested for HIV. Most importantly, all South African government departments leading with this 90 commitment. And then apparently we are also updating the BBBEE. Enough general options. I think the concern, more cross-cutting, are we giving enough access to HCT, particularly outside of office hours, and making sure that we're accessing the people where they can be reached. There seemed to be a lot of consensus for shifting HCT out of the facility into the community where people live and work, looking at the opportunities presented by the robots, but also recognizing that the robots have a lot on their shoulders, and do they have significant enough capacity and support, and will the quality be at the level that the HIV test will also be recognized by the nurses inside the facility when they refer in. We spoke about these innovative opportunities around the social franchise model and letting the market forces help us drive HCT into the community, incentives and discussing who should be incentivized and what's the proportion and the magnitude of this incentivization. And then also looking at technology and seeing if there isn't an opportunity to create a health Uber to find your nearest HIV testing and book your testing appointment and get the people to come to you. We spoke about the mobile testing units. There were concerns about them maybe being very expensive and hard to maintain, there being a low percentage yield, but also recognizing that it does find a large number of HIV positives, and may also play an important role in relinking loss to care back into the health facility. Stigma and mobilization, there were not a lot that we spoke about that. We really spoke about, are we using the opportunities around the AIDS councils to get a more multi-sectoral response to HIV counseling and testing, and that might play an important role for the ownership with the private sector as well as sustainability post-PEPFAR. And getting more HIV counseling and testing and these issues into the local SOBIs. We spoke about measurement, not very much about measurement. Point of care testing, I think there was some disagreement about how much point of care testing should be prioritized with the testing units in the communities, but recognizing that it's not trying to compete with facility-based CD4 testing, and should really look at understanding, does the point of care testing really help people link faster into care? And I think the only final things we're talking about the new evidence-based and the studies, and was saying that we really need to have a better understanding of who are these 36%. Who are the people that are not already known HIV positive? Understanding that they're most likely the men, and also talking about how do we figure out where they are, how we access them, and what HCT modality they would prefer to access and get into care. And I think those were the general themes, broadly captured. If I have left anything out, please let me know.
Sorry, I'm going to. So what worries me about the feedback, it's had an attack of political correctness. And I really don't think it's what we should do here. So we made some really, and I had the feeling there was consensus that we said no partner should be running mobile testing units during office hours unless it's a strategic way of thinking around. And I think the feedback needs to capture those things. There were very specific things around the public broadcast. So I'll work on this session's feedback and try and get it back to what you actually said. We will also review the video feeds and I'd rather, so we're going to give you, I'm going to suggest that we're not going to send these things out on Monday, which will give us a chance to look at the raw footage of the video recordings to make sure we actually pull this stuff together. And my suggestion is for the facilitators of the next sessions to do exactly that, and for the rapporteurs. I really don't think we should have this conspiracy of politeness. And I know some of the stuff is going to rock the boat, but I think that's what the whole objective is. We've got 18 months, 2.5 years max left. Maybe with a bit of no-cost extension, given that the rand is rapidly dwindling. But we should use this optimally, and we should go flat out to do things differently, because at least that will create a legacy that can be used by government when the onus moves towards them. The other thing as well is that it's something that I'll talk to you again, but I've spoken to Jürgen, I've spoken to PEPFAR, and I've spoken to Treasury. There is a big commitment from Treasury to make up the funding shortfall as the PEPFAR money drops off. But they're only willing to do it if we as PEPFAR partners provide information. So we're going to go through a collection of information. And the big issue that we're going to have to tell them is this something that can be taken over by government realistically, right? Or is it something that needs to be put out for tender to be outsourced? So I think, again, being innovative is going to position you well to get future funding. Doing the same old to run mobile units during office hours, that really, I would not encourage anybody at Treasury to fund something like that. So hopefully that's a bit of an incentive for people to do it. Now, on this other thing, relax, right? We're going to have a coordinated thing between the department, PEPFAR, in collecting this information and putting it in a format that can go through to Treasury. So don't please all swamp Treasury now with emails. But we do have some time to pull this stuff together. All right, so in the next session, the facilitator is going to be Suzanne. So the presenter for the first session is Francois. Francois, you up?
Lekker, and I'll keep it relatively short. We've touched on a few of the issues while we've been chatting. So just in terms of background, when this 1990 story came out last year, I really spent like 6 months being really irritable because I just thought it was like yet another Geneva bloody dictated guideline that we would just kind of have to adopt with no real sense of what it's about. I do think that, however, once I got past the grumping, I think it actually is a really useful way to look at how to approach HIV. It's probably a great way to how to approach most chronic diseases. But because we're so obsessed with measuring stuff in HIV, I think that this is probably the way to go. And to put them into those three big compartments that obviously overlap, and I'm going to show you some of the overlap, is a way that we can actually make sense of it. And I think South Africa is particularly complex because, like I was saying earlier, we actually have got the first 90% in terms of testing. We just haven't got it early enough. And there's some of the other 90s which we'll talk about because of the fact that we have resources. That means we're not Malawi, we're not Mozambique, we're not one of these other countries. So anyway, one of the things that's very important is all of these 390s are time dependent. Just simply saying 90%, like I said to you, in South Africa, everybody got tested because they died at the end of their life and they usually got an HIV test before they died. So we got through to the first 90. We have to get people tested earlier and we need to define what that means. And it sounds like there was consensus at this 500 level. I don't really care what it is, but I think that's a useful just metric, is what percentage of your tests are done above 500. The second 90 is living with HIV will receive sustained antiretroviral therapy, and that's entry into care. And again, that's time dependent. We're actually close to 90% at the moment, as you heard. But the problem is that people are spending ages wandering around in the wilderness before they actually enter into care, and that is a challenge. And the final 90, which is receiving antiretroviral therapy and will have durable viral suppression, that one's a little bit less time dependent, simply because if you don't take your tablets correctly, you get resistance, okay, and with the current regimens. And I'll talk a little bit about why that might also become an issue as we get more and more durable, better first-line regimens. So you've got all three. I think the first 90 we're doing the worst on by far. I think the second 90 is the most complicated one. And I think that the third 90, Wendy's going to show us some data, which hopefully will be good news, but which I think we can talk about mechanisms for actually fixing that. So the first 90 impact on the efficacy, and this study which came out earlier this year in the United States showed that, the United States has been very bullish about test and treat. They want to get all the benefits and all the rest of it. In the United States, this study came out, as I said earlier this year, you wander around in the wilderness for 5 to 6 years before you find out your status. So it's not like we're doing such a terrible job. Other people are doing a very, very bad job in terms of finding people with HIV. But during that time that you're wandering around the wilderness, you're getting illnesses and you are spreading the virus, and all the benefits of earlier treatment are not being realized. So we're very close, I think, to the third 90. I think the patients who are actually in the system probably, and Wendy's going to show you some data that is quite worrying, but I think by and large we're as close as damn it to getting there. I think that the second 90, if you look at women and the mortality levels in around, if just eyeballing the data, I think we're as close as damn it there as well. I think we're very far away from getting to 90% for men. And if you look at disparity levels in terms of the extent of the epidemic amongst men and women, South Africa has the worst disproportion in terms of men and women in the world, if you look at access to care. And one of the things we don't talk about enough is where do we go to that? We're talking about community-based testing and we're going into the facilities. What we're not talking about the fact is that where we're going to go and find even yet more women. If we're going to find them, we really are going to have to think a little bit more creatively. And it was interesting to hear the debate earlier. The other group is that has to be solved and can be solved, that needs political will, is the marginalized populations. I think prisoners hopefully are a captive population, so we can get to them relatively easily. The MSM, James is a model that seems to have nailed that group. The sex workers, we have models which are working out there. Getting to adolescents they're a relatively small population thanks to the success of the PMTCT program, but they're a damn difficult group to deal with. And then finally, migrants, which is a massive problem, particularly with this kind of xenophobic outpourings that we're seeing, including from our own MEC at Gauteng, saying, these people are all coming all the way across from Zimbabwe to get their 200 rands worth of treatment every month in Gauteng. And the problem with these groups is they do need the politicians to kind of let us get on with our job and get access to these populations. So, and they contribute to a significant number of the new infections, as well as the fact that trying to get them into care has its own set of problems. The second 90, which is like, getting people into care, is not just about getting into care, it's about retaining them in care. And one of the things I'm going to talk about is people returning back into care. The experience, if you ask patients who are coming back into care, You know, they got a job in Limpopo and then they came back to Gauteng. Their biggest fear is being yelled at by the healthcare worker when they come back through the door. And that's often the reasons why they're not coming back. And this retention into care, this return into care, is something we have to increasingly start looking at because of the fact that over 3 million people are actually in treatment, and we don't have good ways of actually transferring data from one province to the next. I do not believe the loss to follow-up data. I'm sorry. If it was really 30%, we would be back to where we were in 2004 in no time at all. And I can tell you the Johannesburg Hospital was covered in bodies in 2004. There is, now we have a couple of sick patients coming in late. Most of the patients have fallen off the wagon. They've got all sorts of social problems. I do not believe this 30% loss to follow-up at 3 years. It just doesn't make sense to me. People are moving between provinces. They're moving between jobs. They might fall off the program, but they're returning into the program. And this is a real, for me, the loss to follow-up, and it's, as I said, it's just my opinion, I might be wrong, is the fact that this is a failure of the tracking devices. I was in Eastern Cape yesterday, and they've got their whole new system for tracking patients, but it's only specific to Eastern Cape, because nobody ever leaves the Eastern Cape. And it's bizarre to me that we still haven't fixed this. We're just not tracking patients, and that's the reality of all of the stuff that we're doing. And I know every M&E person is probably frantically nodding their head at the moment, but we really don't know what's happening out in the ether. I honestly don't understand why we're not allocating this to the NHLS. We've had a decision around a single patient identifier, around the ID number. I don't understand why this is not being implemented. We would understand so much better. We should be outsourcing CDC and USAID should be allocating funds directly to the NHLS to outsource all of this tracking program. Instead, we're having every single province and every single PEPFAR program and everybody doing their own thing around this when we know that none of us are going to come up with a solution alone. The NHLS is the only organization that has a national footprint and the kind of integrated systems are actually going to be able to tackle this. We would know how many patients we're generally on, we'd know what CD4 counts we're starting, what the viral load suppression rates are, but instead we're going to have the Eastern Cape rolling out its own system again in specific facilities. And again, a plea for me is that we should really start thinking about playing to our strengths, and the NHLS is a significant strength. So very quickly, just to remind, I'm actually going to take you through this. Many of this is very new data, and some of it I think is data which people didn't appreciate the nuance on. This study that came out a couple of years ago in Science, 3 years ago, Frank Tanzen's group looked at them in Matuba in KwaZulu-Natal and demonstrated that for every 1% increase in ART coverage they got, there's a 1.7% decline in new HIV infections. So this correlation between viral load suppression and new incident infections is very, very, very clear. What's not appreciated from the study is a lot of that happened at the CD4 count of 200. They rolled out, when they looked at their database, remember that the CD4 count went to 350 only in 2010. So they realized unbelievable HIV protection levels at a very low CD4 count. They didn't report in the paper what the average CD4 count was, but I suspect it was in the realm of about 100. This is very good news, and in fact, I think that you're seeing it at the moment, starting to play, and why we're seeing the triangulation of data from StatsSA and other people is making a whole lot of sense, is because I think the HIV programs actually had more of an impact on prevention than we actually think. So we've made sex safe. We have the study 052, which was the heterosexual study which looked at discordant couples. And we have this amazing study, the partner study, which is enrolled, is an open label study where they enrolled discordant couples where one's positive, both gay and straight, and where one's negative, but the negative's not allowed to be in the study if they're using anything. That's no condoms, no PrEP, no nothing. And there has not been a single HIV transmission in the study. In the 052 data, which was released last month, there were 8 transmissions. Every one of them was with a detectable viral load. So for the prevention stuff, we have to get the viral load down to 0. And when you get down to 0, those people are actually essentially sterile for the virus. It's incredible, the extent of that. And in some ways, I can understand people, I gave a talk about this at Vancouver, lots of people saying, let's get rid of all the other prevention stuff. Let's just focus on finding people and treating them. And there's mathematical modeling suggesting why we can't actually do that. The problem for this is that the benefits above 350 have been unbelievably marginal. The believers believe it. The non-believers like me didn't believe it. And in fact, this very large study that came out, observational study that came out in Lancet just a couple of weeks ago, just before the Vancouver conference, demonstrated very, very small benefits to starting the ARVs above 350. So it's all very well when resources are not a constraint, but in our situation where we're paying a lot of money for this, that is difficult on a public level, health level to justify. But then these 2 studies came out last week in the New England Journal, which pretty much have settled the debate and shown that there are significant benefits to starting earlier. Both studies showed a relatively similar drop in new incident infections of TB and pneumonia mainly at treating above 350. So this debate is over. There's nothing to talk about in terms of when to start. And I know there was some talk about point-of-care CD4 count testing. Government's already costed the fact that they're going to go to test and treat. The whole world's gone there. Swaziland's announced it, Zambia's announced it, WHO has given provisional announcement and will announce it formally in December. I don't understand why South Africa would sit behind it. I think we're going to go to test and treat, and I think it's going to make, for many of us, our lives much, much simpler, actually. But the problem with that is people are going to be entering the system at an earlier CD4 count when they're healthy, not when they've got cryptococcal meningitis and TB. And that throws up all sorts of adherence issues, which I'll talk to you about in a second. The other thing is people forget. Everyone's saying, oh, we knew the result all the time. The reason this result was so profound is they did not use D4T or AZT. They used tenofovir. The program is completely dependent on us having safe drugs. The good news, though, is that programs are starting to improve. And this is what I was saying about earlier, is this is entry into ART. It looks at the average CD4 count when people enter the system. And it's important to recognize that in 2010, there was a bit of a jump in 350, and then last year to 500. But the percentage of people who are starting ART at a higher CD4 count is steadily increasing. The number of people in our own program who've got active TB is steadily coming down from 10 years ago where it was 25%, it's less than 10%. So this is all excellent news, and something that programs are now going to have to deal with is the fact, as I said, healthy people coming in. Life expectancy has gone up, and as I said to you, if 30% have lost to follow-up at 3 years or 2 years or everything else, this wouldn't be happening so profoundly. People are staying in the system. As you can see, it's more profound amongst women, mainly because they're younger, and you're putting them out of the system, and they're accessing care better. This is really interesting news from the NHLS as well, which showed across the country, as the coverage of ARVs has gone up, the incidence of TB is coming down. Okay, and it's fairly consistent across every one of the provinces. And I think, again, for us to get on top, I'm not going to talk about the 1990s for TB, but for us to get on top of the TB epidemic, this is obviously a critical component of trying to get coverage going. And it's good news because we've got something we can actually offer the TB program. The viral copy transmission now has been shown to be 1,500 copies. Our program is 1,000 copies. It's fairly arbitrary what that looks like, but this is what is going to be the magic number. We have to get them down to 1,000, 1,500 copies. What were you saying, Wendy? You was like throwing your hands up? Oh, you can give it. The problem with this is the retention stuff. It's keeping people in the system, getting them there and then making them stay. And the problem is this, is the health system is unfriendly and increasingly it's unreliable. And it's something I often think that the ARVs work despite the healthcare system and doctors and nurses. And it's also reliant on a global manufacturing and this active pharmaceutical ingredient industry, which is not terribly reliable. This shows you the cascade. Andrew Hill presented this in 2015. It's impressive at the moment. But shows this dramatic fall off in care. And it varies from country to country. But from the point of testing to entry into the ARV program, routinely in every single country, 50% of the people get lost in that one step. The problem is people think that loss is forever. I often think people just wander around thinking about it for a while and then eventually enter the system. So it's not like it's a permanent loss, but you can see this dramatic drop. And the problem with that is your initial investment in CD4 count testing and all the rest and the counseling and stuff is lost somewhat in that loss to follow-up. This is also interesting. I'm not taking away your thunder, Wendy, but if you look here, it also depends how strong your healthcare system. The Americans were always being rude to the Brits about the fact that their CD4 count threshold was unlimited while the Brits stayed at 350 like the South Africans did for most of the time. If you look at the healthcare system, suppression rates are much, much lower in the US than in the UK. And again, it's about having a good healthcare system. It's not about magical CD4 count thresholds or new drugs. This looks at loss to follow-up from Sydney Rosen's group here in Johannesburg, from the Right to Care group, and has demonstrated that across all the countries, these like loss to follow-up things are worrying. As I said to you, it doesn't make sense to me that these people are actually lost. We probably need a different term. They're moving somewhere and we haven't captured that. Andrew Bull in the Western Cape has demonstrated the same thing, and what's interesting is as the program has matured, he's demonstrated that it's getting worse and worse and worse. Again, I just think that maybe we're just treating normal people who are crossing borders and are kind of going there and back again. And certainly in the Western Cape, they've got very, very good outcomes in terms of their program. But this kind of tracking of patients, I think, is a major, major problem. This, again, is Sydney Rosen's group looking at different programs in terms of 48-month retention. And if you look here, there's a dramatic difference, you come right down here to Cameroon where there's a shocking program, and up there where there's a South African and Ugandan program that is not so. But what I take from this is that actually there's a lot you can do to get up there. You know, the fact that there's such a discrepant number of results, even amongst the South African sites here, is that we could start looking at what puts the program up there and doesn't put a program down here. So the other thing about this is that this is for life. We've got the earlier you can get them into care, the longer their life expectancy. And you can see like the life expectancy here, if you start above 350 in the UK, is now 81 years old. In fact, most people on ARVs in America are over the age of 50. It's an old person's disease. So, and we're getting there. You know, there's a hell of a lot of people now who are suddenly living 10, 15 years into the program who are now over the age of 50. The problem with it is the drug stockouts issues. When they looked at START and Temprano, a lot of the results there, that was a clinical study where there were no drug stockouts. About 80% of the drug stockouts we're seeing in South Africa at the moment are supply line issues, but about 20% of them are actually just drug manufacturing issues. And I was having phone calls last week from about AZT and 3TC run out in northern KwaZulu-Natal. The week before, my own hospital, the Centre of Excellence, Johannesburg Academic Hospital, ran out of Aluvia and amphotericin. So we do need to start looking at this as being something. We can't have a situation where we're emphasizing adherence and yet we can't actually supply the drugs. The API production capacity is absolutely massive, and again, 80% of our generics are coming from India at the moment, and well, it's slightly less in South Africa because we have Aspen, but across Africa, 80% of them come from. So we're very dependent on one country's manufacturing capacity. The other issue is those of you who've been living under a rock for the last few weeks may have noticed the rand getting slightly weaker. And this has huge implications because these chemicals come in. And for some of the companies, actually, it means that ARVs are not profitable. They actually lose money manufacturing. And it, again, puts these companies, these systems in put. Gustav is talking about the warm and fuzzy stuff around stigma and systems. This is something, getting people to test involves dealing with stigma and systems. The issue of adherence around stigma and systems. And then, as I said, the re-entry into systems. Lindsay and the NHLS are busy with various apps that pushing results to both healthcare workers and pushing results to the patients. And we're certainly looking at an app where we try and push CD4 counts and viral loads to the patients. Gazina and the group have done the investment case. You heard them talking about. And I think the thing about the investment case for HIV is it's currently already 2/3 funded. That it's not going to take a hell of, it's still expensive, but when you look at the amount of pathology that HIV causes relative to other diseases, HIV is probably, TB oddly enough, are probably still relatively underfunded. But for the relatively small increased investment, granted off quite a large base, it's not that small, we can probably get to a situation where the HIV program is fully funded. So just, I think my last slide. So I just wanted to end this. This is one of our projects. We've been treating sex workers in the inner city of Johannesburg and Pretoria for the last while. So we're in this verticalized program and we go to sex workers and we say, if you have HIV, here's some ARVs. If you don't have HIV, here's some pre-exposure prophylaxis. This is the kind of study design. At this point, we haven't lost a single patient in the program. It's been running for about 6-7 months. It's incredible. Do you know why? So I'll show you the next quote. So some of you have seen this quote. So a lot of these patients are Zimbabwean. One of them was speaking Shona, and one of our pharmacists heard this person. This is not a clinical study. This is like SOMA, part of verticalized service integration project where we just hand this out. So she heard one of the patients saying why they feel so good, and this is it. They're so nice to us, they treat us like white people. This tells you everything you need to know about the healthcare system. If you treated people with respect and some sort of dignity, they will come back and they'll take in whatever you give them. These are sex workers with very, very chaotic lives, but they feel valued. And these are not like special nurses. These are simply nurses who actually smile when they do their work. And I think, for me, this is like why we're going to fail if we're going to do test and treat, or any of the chronic disease programs. It's because we're not able to yet deal with the fact that our human resources are actually quite grumpy. So this paper is about service delivery. And so the challenges, I think, this is my last slide, which are very, very specific to test and treat, is we have to get the retention and tracking programs right, and we have to prioritize the NHLS's single patient identifiers. I just feel like that's going to solve so many of our problems, and the problems of the hand-wringing around retention and care, we will sort out once and for all whether there is a problem there or there isn't. The return to care has to be made easier, and this kind of situation, and it's actually, again, I was doing some work in the Eastern Cape and here in central Johannesburg. It's actually the clerks at the front who are the worst. Actually, it's not the nurses and the doctors. They certainly contribute to it, but the kind of bureaucratic impediments that are put into terms of coming back into a program is a huge, huge problem. We have to get an easier, cheaper, more robust first line, and this actually we'll have solved probably by 2018. We'll have a tablet the size of an aspirin that is now going to replace a triple generic, which is almost impossible to break. So we will not have to wring our hands about resistance and second line everything. We'll need to have point of care viral load, not point of care CD4 counts, which will probably tell the patients that they find they can come back in a year's time. And finally, the second last thing is just that adherence interventions need to be more nuanced. People fall off adherence because of crises in their lives. They lose their jobs, they break up with their partner, they start doping. It's all those things that are actually happening. Instead, they get a one-size-fits-all adherence message that every single person has to deal with. And I think that we need to have our interventions surrounding them that much more nuanced. And finally, just we need to find some way to deal with the friendly. Gustav was complaining about the fact that we haven't had health like stuff dealing with management and stuff. But I honestly think that's going to be far more important than these new drugs, these new CD4 count thresholds, and all the rest of it. Is trying to find some sort of booking system or some sort of way to obviate getting past the healthcare system that doesn't mean our patients have to engage with people who are actually not as invested in their care as we'd like them to be. Thanks very much.
Thank you very much, Francois. We asked you to be provocative. You really were. I mean, expecting healthcare front offices to be friendly. I don't know if you noticed this, but doctors haven't got a clue how to put user-friendly services in. So if we go into private practice, we really think it's a good idea to make our mother-in-law our receptionist. Next time you're at the practice, go look. It's the mother-in-law. They sit behind this counter that comes up to here. You just see the glasses and the grey hair. And I have a deal with my cardiologist. I am the first patient in the morning so that I can get out. I really don't have hours to sit around. So I pitch up and I see there's stuff happening. Now what I didn't realize is that clinical trials overrides any patient's requirement. So there was clinical trial things going on. And I got jittered. And after a while I sort of started saying, and that sort of, those glasses sort of lift up and they settle down. So I thought, okay, I'm not going to get prompted. So I sort of said, excuse me. And the next moment she sort of looks up, she says, what? I said, how long must I work? And she arose like a demon out of hell over that counter. Doctor is busy. Please wait. Right. If that's what we do in the private sector, the public sector is worse. So I do think it would be interesting. And it really would make a fascinating conference presentation about what have we done to make the service friendly. Because I don't think we focus on that. So that would be, for me, the first big take-home message as PEPFAR partners. Go and do some pilot projects, tweet about it, do something, but try and create services that are actually customer-friendly and patient-friendly. And I don't think we can use those two words together, because the patient part, I think we're good at. The patient part is that 5-10 minutes while the patient or the person is interacting with the healthcare provider. But the part that we suck at is the customer part, because that's the part from where they contact the facility until they've got their lab results, they've been seen by somebody and they've left. So one of the things that's been suggested is that we should insert into healthcare services customer rating systems, right? That people can actually, with a mobile phone or something, rate the service, and that somebody actually takes cognizance of it. So that stuff goes back and feeds back, and if a clinic sucks, then maybe it should cost the manager's position. So I've now made the completely irrelevant speech instead of answering a question. Right. The floor is open for discussion. Who wants to kick off? Okay, Suzanne, the part that's missing now is what is the hot questions that we should be focusing on. So let's just start off with this thing about making services friendly. Has anybody got any experience or suggestions about how do we address that component? Right. Yeah. Okay, new rules of the game. Recorded for prosperity. Gloria, on the microphone.
Thank you. I think one of the things that we need to remember is that the healthcare industry is a service industry, and a service industry depends on people. people. It depends on the relationships that you build with your customers. And one of the things that business is doing well in the private sector is that some of the businesses have started developing what we call customer relationship models. Yeah, and there's a whole research into customer CRM models that perhaps that, it's something that we need to start thinking about, and to try and build relationships with our patients so that we can retain them in care. And one of the models we were kind of thinking about is, for example, when patients go to a mobile site and they test for HIV, perhaps what we need to do is that at that point in time, start thinking of ways of building relationships between the healthcare providers and the patients. That could be something like allocating a patient to a specific counselor where you have the contact details of that patient, and that counselor will be able to contact that patient and say, hey, you've just been tested, perhaps you could come in and I will be waiting for you. I'm making an appointment so I can come and see you, so that when the patient returns and gets back into the health services, they know that there's somebody who's expecting them and somebody who's walking to walk the mile with them as far as care is concerned. And I think if we can address that, perhaps we'll be starting to address retention in care.
I have a very good idea as well, as been discussed in the past, is that patients are waiting in queues for hours in facilities. There's nothing better than empowering them and making them feel important, and that's what the whole discussion is about. So you can have some sort of mobile technology where you do a survey on that facility, and you incentivize that person to take that survey. So they're getting some sort of informal payment as well on their mobile phones to complete the survey. It's a task. And then those tasks, or the performance of those tasks, should actually be related back to the KPIs of the healthcare workers in the facilities. So that it's taken back to the house managers and they manage it that way. So then the patients are making contributions and suggestions on how facilities can improve. And these suggestions are taken back to the healthcare workers. The healthcare workers can see how they can improve on their services, and at the same time, patients are getting some sort of informal money. Thank you.
Another radical suggestion there, that we actually link performance to bonuses and things like that, KPIs in the public sector. Wouldn't that be nice? But again, I do think there seems to be quite positive support coming back for this thing about creating some form of feedback mechanism that clinics get rated, etc. The incentive would probably be the airtime again. Is there anybody who's working on these things? Hands up. Okay, Suzanne. Right. So, and it's only the two organizations. So we will get you to work together. Right. Let me get that, because I think it's worthwhile. Again, we've got enough time to get something like that. James, are you in that space as well?
Yeah, we're looking at something particularly on the MSM track, and that's the shortcoming. So we're in the group, that's in the group. If you've got group. Quick comment to say we're looking at something to evaluate the MSM trained clinics that we're training in the public sector. We haven't started yet. We'd like to be in.
Okay, you're in the group. Right, Andrew. You've got reference prominently there, so you're going to defend the slide.
No, I won't defend it. No, I hope not. I said the one problem we have with friendly services is our patients have got used to such low standards. We did a survey where conditions are shocking, and the patient thought the service was excellent if they were actually seen by somebody and got their drugs within the same day. So I think we need to educate patients as to what services they can expect, and part of mobilization is patients should start putting pressure on health systems for proper services, not just what they get in.
Okay, I think this is important. There was a survey done amongst parents about their perceptions of schooling in the public sector, and 85% of parents thought their kids were getting excellent schooling and the big reason was because they were being schooled in English. At that stage, the intervention we wanted to do, but we could never raise the money. So in case one of you have got a few millions to throw in the direction of Soul City, we actually wanted them to incorporate into one of their seasons something that actually makes the public understand what is good quality care services. Because I do agree, and I think it's very important that you raise here. We can go and put in the performance appraisal stuff, etc., and we're going to end up. We've been doing ratings, paper-based ratings of patients of clinics for years. And there's a few things we realized. One is if you don't own the box that's bolted to the wall and locked, all the negative comments get taken out. Right? So the management of the clinics want to massage it. So once you get past that thing, you've bolted the thing to the wall, you know the combination of the lock, they then stuff the balance. So they put huge amounts of, we got brilliant service, etc. So I do think it's a slightly more complex, and I'm glad that you've added that to the nuance. Has anybody got another suggestion apart from writing a check for Seoul City that we can use to educate the public? Then I think somebody should volunteer to give them some money. Okay, you're volunteering the money.
I know, unless there's a big promotion. I think linked to educating the patients, what we were looking at with engaging with the client experience was the opportunities with the mobile phone technologies, but also whether there's opportunities with the touch screens and the screens so other patients can see other people's comments as well. So I think if we're talking about educating the patients, allowing the patients to learn from other patients, to see if they're upset about one thing, maybe they're also upset about the same thing. Or they accepted that and someone else is complaining and it makes them question that standard. So I think the information needs to also be accessible to the patients.
Anybody else who's used mystery patients, ghost patients, anything like that? So we did it. We had the NHLS did mock-ups for us for lab results. We sent medical students into clinics. We gave them questionnaires to fill in. Originally it was, we printed the things and stuck them into the U magazine so that people didn't realize it. Now it's more putting it onto mobile phone. The results you get is horrendous. Right? Okay.
So I think this discussion is going down a dead end. Problems with quality in the public sector clinics have been there for the last 20 years. I think everybody knows these problems. The challenge is how to solve the problems, and I don't think that PEPFAR partners are going to influence this in any meaningful way. So I think that the brainstorming should focus on what PEPFAR partners can do to alleviate the mass of HIV patients in the clinics and take some of the pressure off, and also the extra 2 million patients that have to be put on treatment. How can PEPFAR partners come up with solutions so that they don't enter into the public sector and put yet more burden on the existing clinics? I think there's an ideal clinic initiative which recognizes the problems of quality, and they're struggling to improve it. We've got a system that's semi-federal, and National Department hasn't got much power to influence the provinces to be accountable and be responsive.
Okay, so that bollocks the interventions around. But I think what Peter raises is, so again, if somebody's going to try and create friendly service, please do it and let people know if you're successful. But I think Peter raised a very important subject, is this thing about the public sector probably can't cope with another 2 million odd patients being dumped on it. And there is a lot of work that's been done, a lot of you have been part of that. This work about the think tank to try and come up with alternative models, and there is a bunch of pilots being tested about treating patients within the public sector environment. Francois, you joined the queue.
So I hear what you're saying, Peter, and I agree with much of it. I think you have to fix the healthcare system. I do want to caution people from throwing up their hands and saying the public service is so overburdened. The public, if you look at WHO staffing levels, we don't even feature in the critical areas. We've got enough staff to do what we need to do. I was in Swaziland last week in a really busy primary healthcare clinic. They had far fewer healthcare workers. They were really working with queues and people moving through it. It was just much better organized than half the places I had taken. So I think that you're right, we need to be fine, but we mustn't start saying the public service is so overburdened. What we need is a better management of those services. And I think what the PEPFAR partners need to do is start looking at easy ways to start doing it. The other thing we need to do is to find alternatives for service delivery. Like, I can't believe, and some of them are actually coming out of the Department of Health, why patients can't get their drugs delivered to their homes. If you're an HIV patient, your viral load is undetectable and your weight hasn't changed, you can get this damn stuff delivered to your home once a year. That's how it works in the States, it's the way it works in Europe. It means they don't have to come to the clinics, they don't have to sit in a pharmacy in underrepresented areas. So I do think that where PEPFAR can help is to start looking for these innovative delivery things, and then also just support some of the DOH initiatives, which is this chronic delivery stuff, which my impression is it's very, very badly advertised more than anything else, because the uptake was initially certainly very, very low, or it certainly wasn't last time I heard. So that's where I think PEPFAR people can actually do and help. I do think that you're going to have to fix the whole of the healthcare system and make it friendlier if we are going to make this work for the HIV program.
So in theory, if the government policies get through on NHI, what you effectively do is you outsource the healthcare service. That's really what happens, which will make it friendly. But just to correct something that the professor said, I love it. Don't you enjoy correcting a professor? He quoted WHO staffing norms. In terms of doctors, if we compare ourselves with middle-income countries like Brazil, we have a shortage of 60,000 doctors. Right? So it's not that we have enough healthcare professionals to throw around, but I do agree that that it's not as in lots of clinics they aren't overstaffed. They're not understaffed. There's enough people, and services do not run until 7, 8 o'clock at night. Right. So, but the big suggestion here for us as PEPFAR partners is find initiatives that you can align with that will reduce the burden on the public sector. I think there's a big one that Francois raised, this chronic delivery of medication. That's something we're all involved in, adherence clubs, stuff like that. There's a huge opportunity for us to promote that. I just wouldn't know how to promote it because I wouldn't know where to find the information. So does somebody have the information? If we wanted to market the adherence stuff, will you send it to one of us at FPDA? We'll distribute it with the video, not the videos, with the slides and the reports. Okay. Wendy?
I think one of the things we're not using the PEPFAR partners for is training and appropriate training. And we forget, we do all the clinical training, but we forget that to get a test into a laboratory or to request the right test or to interpret a test is actually very difficult. We need people to be able to go out and say, well, here's the list for your clinics of viral loads greater than 1,000. Go to your clinics, teach your sisters what they mean, and so then we deal with exception reporting rather than just a mass of people we are not sure about. The same thing goes for MDR drug resistance. The other thing that's a problem, no one actually even knows how to cough properly to give you a TB specimen. They don't know how to take extrapulmonary TB specimens, pediatric specimens. So what I'm saying is that a big role for the PEPFAR partners, certainly from the NHLS side, would be to use your resources and legs. I mean, I have a total of 10 trainers. How can I do EID, gene expert, drug resistance? But with simple messaging, you could assist with the legs on the ground so that people start understanding the tests and then using them. Because we do many more tests than are used properly in facilities. So it's not just about getting the result to the facility, it's the pre-analytics that is just as awful as post-analytics in many instances. So.
Okay, I think it's a very valid point. We've all got roving teams going out to clinics in the districts which are being prioritized. So Wendy, we're going to give you to-dos. You're going to have to send us your to-do list. You're going to have to send us any materials you've got, etc., and we'll distribute. Okay. Cordelia, you were sticking your hand up, but you've got to come to the microphone.
I'm covered because for me, the only thing that came in terms of client care service was more of how as partners, as PEPFAR partners, can we assist the department to look into our care of the carers, our professionals at the facilities there, to link them, how to assist them, to link them to the employee assisted programs, because at the end of the day, even the carers have got their own burden that they might even project to our patient. How do we assist the department then to activate those departments?
Thank you very much. So there's an input here that part of the unfriendly services. Yeah, I'll agree to disagree with it because I'm going to say something that will get me hunted down in the streets by nurses. So let's Point taken. We'll put it in the report. Right. Are we wrapping up the friendly services?
The friendly services, yes.
Okay, so
I think as a follow-up on the point that was mentioned by Francois, there are modules like the health posts. The modules like the health posts, that are, it's a government intervention, but they are not really fully utilized. I think if PEPFAR can be looking at strengthening the health posts, the issue of health posts, and in addition to strengthening the issue of health posts, looking as well into is the health post and the issue of strengthening the support groups. Because when a client, a patient goes to the clinic, you are seeing a service provider who is very busy, who has got a lot of patients to see. But if you utilize your support groups, for example, and if these service providers at some point in time they are seen as part of the support, talking to people in a relaxed and friendly setting in those sessions of the support groups, I think that what can be really one of the vehicles to improve the services, where in an environment where the nurse will say, if you have any problem and you need to ask any questions or you need just to talk, here is my phone number, or here is so-and-so's phone number, you can actually engage with this person. The issue of the medication from the clinics or from the hospitals, actually getting to the patients. It can be at home, which is going to be another way, how do we get that? But if you are getting a health post is within a community, particularly those communities that are very far from the clinics themselves. So the question is, if we were to strengthen that, who do we put and who do we train in that health post who can keep on referring people back to the clinic and coming back again to the health post and talking to the people who are manning the health posts?
can I just verify, the health posts are in the context of the community health workers? Am I right? Is that what they're supposed to be? This is where, okay, got it. I think community health workers has come up a lot here, and now it's the health post linked to it, etc. All right, we're going to wrap up. We're now going to move to the next big thing that was raised. Tatu, do you want a burning statement to make around friendly?
No.
That's moving on. Huh? Okay, that's something else. Come and say something else. We've wrapped up this thing about the friendly services, etc.
Definitely nothing friendly. No, for me, I just wanted to bring out the issue of with the second 90, from the first 90 after testing and identifying clients, that I know it's about linkage and retention, but with the linkage, I think between PEPFAR partners and what PEPFAR is saying is to be clear, what is the role of the testing partners? How far should the testing partners go? Should it be mandated that once the PEPFAR partners have tested, you don't just test, but part of testing goes into ensuring that I have linked this person into care, and then the rest will be taken care of in the second 90 in terms of retention? Because I think Francois and everybody else has really mentioned that there's a lot of testing that is taking place, but people just linger around after learning their HIV status.
Okay, it's a great subject to move to, so we're going to switch now to discussions on, so the first is a very specific question. If you are a testing partner, does your job stop after you've done the test, or does your job stop after you've linked the person into treatment? Right, everybody's nodding their head, so congratulations testing partners. You can't blame the district support partner for not picking up the patients they don't know you're testing. Right, so we all agree. We have to, if you test, you've got to do everything in your ability to link the person into treatment.
A couple of months ago, they were looking at the data, for, comparing those that were given VCT, and they were, and half, I think it was half were put into treatment the same day with rapid testing, and others were not. And getting that rapid testing and getting people onto treatment the same day at 12 months had no difference at all. There was the same dropout rate, there was the same failure rate. So it's about nuancing, it's about respecting the client, it's about saying test and treat, it's about getting the result to people and then saying, when are you ready for treatment? When can you get onto treatment? It's not just as simple as saying that the testers have got that responsibility to get people there. Of course you have to. You have to link them, you have to show them where they can go, they have to be counseled about the importance of it. But it's, to my mind, it's more nuanced than that. The importance is quite clearly there, but the sense that if you give people this direct link to treatment, if you get the referral letter, that automatically that's going to have better outcomes. And I think the data now shows that it's more nuanced than that, and we need to offer more support, more friendliness, more individual patient opportunity to engage in a better health system. It's not just linking, it's something more than that as well.
Before we go to Andrew, I'm going to go back to Francois. Because you had these slides up about how well countries are doing. Is there anything, I mean, what do the Swiss do better than anybody else, apart from being Swiss?
Look, I think the National Health Laboratory Service is free, it's well run, the queues, despite all the grumping and complaining, and there's huge investment in the systematized, socialized form of medicine that is equal for everybody pretty much. It's being dismantled at the moment, but that's the problem. Swiss and in Dutchland as well, if you wander into a clinic, you get a really good high level standard of care and you trust your service provider. We have this incredible disparate, I mean, it's a lucky packet in the private sector, but it's definitely a lucky packet in the public sector. So I don't think we can look to them and ask for like quick fix solutions. I do think that there are innovative ways to get past the healthcare system that we haven't explored yet. Like I think the classic system of going to a clinic and seeing the nurse, picking up your medicines and going to the pharmacy and then collecting your, I don't understand why we actually buy into that stuff when we don't have the resources to actually give it. And this is again where I think PEPFAR creativity could be used, is to start devising systems that actually could be just more creative than that. You're already seeing it starting to happen. You see it with the adherence clubs, the MSF have got going, you know, that systematized, centralized areas where they actually dispense medicine. You're seeing within the Department of Health that maybe dispensing is trying to get going. I really think we need to be playing to those to try and get people out of the system. And just on the nurses, you were asking if you read about nurses. One of the things I think we should be doing more is understanding why are these, I was just looking at this ground-up article about this poor person whose baby died, and nobody told her that the baby had died until she went to the morgue, and she realized she gave birth, and there's this huge drama about this baby. It's like, where does this compassion, fatigue, and everything else come from? And we actually need to do research. We can sit here and come up with all our theories and things like this. We had a researcher sit at the gen and ask nurses where their stress came from. You know, and I was like, I've got an opinion, I'm sure you've got an opinion. It was like doctors shouting at them, shift work, all the rest. The single biggest stress had nothing to do with work, it was their husbands and their partners. And the family expectations around them as providers, which gives you a very different intervention around nurses than simply saying doctors be nice to them or have better shift work or pay them more money. And I think trying to pay a little bit more attention to what the healthcare providers are saying and what are those stresses probably would go a long way towards understanding what those interventions need to be, rather than us sitting in a group who, most of whom, let's be honest, don't use the public healthcare service, and those of you who are nurses probably haven't nursed for a while. You know, then trying to come up with theories as to how to deal with the nursing, particularly the attitude problem. The same would probably go for the clerks and for the pharmacists and for everybody else.
Okay. Back.
Thank you. It's back to the treatment part. My question is, and I think it's something we need to decide together, is when must we start treating these patients? You've mentioned the nuances, and I think they need to be recognized. Pregnant woman, it's easy, the sooner the better. But are we now going to have to go to facilities and initiate everyone on the same day because we're chasing the target, which some people are suggesting, or are we going to make a reasonable time before following up and allow people to wander in the wilderness for a while? As we've heard, there's no rush to go galloping and get people on treatment immediately. And I think we need to work out what is a reasonable time to expect a patient to have gone to a referred facility, and when do we start chasing them, rather than as soon as we diagnose them, give them the tablets and think just because we've done that, they'll come back again later.
Thank you. Okay, anybody else who wants to add to the linkages conversation? I do think the big take-home message is trying to find ways that we don't have to schlep a patient from their house into an overcrowded clinic that's not probably providing terribly user-friendly service. So that's the innovation. And those of you who haven't done it, we found that certainly USID is very amenable to you now testing new models and stuff, etc. The only thing is the emphasis is you've got to move reasonably rapidly because time is ticking. Right, the other big issue that was raised here in Francois' discussion is around adherence. And that drop-off on adherence, although he did say he doesn't think it might be more a reporting issue or inability to track patients. Is there anybody who wants to weigh in on the subject about what can we do with the time that's left around adherence, improving re-entry into the system, those subjects?
That not fit in the last slide.
You want to fit? Okay, it's a retention thing, so we'll skip that one. Okay. Return to care. You want to discuss it under the last 90? Yes, they're nodding. Wendy's worried we've taken all the slides away. Join the microphone. See, I spoiled you during the first session by rushing up to you.
I mean, yeah. Josh here again. I don't think it should be relegated only to the third. We have some evidence of, and I hate to put more burden on the ward-based outreach teams, but we've got some evidence of community health workers tracing defaulters. Have we said that already? And that's a means to addressing retention. And again, I'll have to bring up tier.net as a possible opportunity to link care. If you merge all your data and look at it at the district level, you can see self-transferring patterns if you find someone appearing in multiple facilities. And something that Prof. Venter talked about in his presentation, I'd really love to know the actual loss to follow-up rates. I believe there's research happening which will hopefully better quantify that through modeling. Thanks.
Thank you very much, Josh.
Thank you. No, I just wanted to comment on the issue of the loss to follow-up rates and the important point Francois made about tracking programs and not believing the data. Because I think if we're going to invest in bringing many, many more patients onto treatment, then I think we need to invest in making sure that we do have credible data. And if we don't believe our loss to follow-up rates, then I think it will be very worthwhile investing in a quick study, and it doesn't need to be a very long process. Some of this can be done where you now try and find out where are the leakages happening. And then if you do find out where the leakages are happening, then you can invest in doing that. You know, in a previous experience I had with the Botswana treatment program, we were losing about 30% of our patients in terms of the follow-up sputum data, and couldn't work out why this was happening, and we knew the rates were high. And it was simply going painstakingly through the lab processes, following the data. We were then able to get about 70% of those patients' data records back into the system. So I think for me, we do have alarming figures in terms of the loss to follow-up, and if we're going to invest in bringing more patients in, then we need to spend some time in making sure that we either believe the data and then we're trying to improve it, or then have improved it and then can then focus on bringing more patients in. Thank you.
Okay, well, thank you very much. I guess HST just volunteered to do that quick study. See, he's volunteered. Okay. But I do think it's important, right?
So I think I, like Francois, don't believe the loss to follow-up is as high as it actually is. And the only way to fix that is to get a patient-based system with data linked to a patient in place. And the only way to do that is for PEPFAR partners, every time a patient gets into tier, to make sure the ID number, or for those patients who haven't got ID number, the secondary number is entered. And every time there's a lab investigation, that same number is entered, so that ultimately you can use the NHLS database without complicated algorithms to track individual patients moving between facilities, and then you'll reduce the loss to follow-up rate quite easily. So it's a practical suggestion. Get tier up to date in every facility that you're working in. Make sure the ID numbers are in tier, and all the lab results also have an ID number.
Peter, don't go away. How does the alternative number work?
I'm not sure exactly, but for people who've got passports, who haven't, foreigners, Zimbabweans, there's a number generated by the department and been allocated to facilities to use that number. Maybe Romy knows the technical.
That's what I know as well.
Yeah, okay. We can get the details to you from the Melanie Volmerance's unit.
Okay, so again, I think it touches on what Wendy said earlier, is that there is a need for us to ensure that our support to the facilities start focusing perhaps sometimes on some very elementary issues. What tube to use to draw the right blood, what number we fill in. So again, I think it's a really good, very practical suggestion, and I do think most of the PEPFAR partners probably have it in their strategies to make the tier.net system operational, and we will reinforce on this. Everybody happy about that? Okay. It's not sexy, but it's necessary.
Yeah, I think that the suggestions are all correct around we need a unique identifier, and you were asking for the politically incorrect stuff. We have to understand that the issue of a unique identifier has cabinet approval, it has National Department of Health approval, it's a political issue at a provincial level, and it is the time to be subversive and to say to those of us who are working at a facility level that this has cabinet approval and put the ID number in. There's an algorithm to answer your question that if you don't have an ID number, then you go to a passport. If you're not local, it goes to there's a whole algorithm that's in place and a temporary number that can be issued, etc. So go to the facilities, and the advice we must give them is that we have cabinet approval for the use of an ID number, that NHLS is ready to is using it already, and that is the only way that we'll get the data on loss to follow.
Can the NHLS refuse to do a test if it doesn't have a number?
Not an ID number. So there's an electronic gatekeeping system within which there's a set number of fields that you have to have filled in. And then even within that context, if there isn't an ID number, there's an algorithm to work out whether the person in this at this date is the same as the person on the next date. And even there's a high degree of ability to follow patients up. But just look at the protocol for electronic gatekeeping. There's a set number of fields that need to be filled in.
Wendy?
Of which ID numbers is not one.
What we can then do as the partners is try and get at the facilities that the numbers go in. But I've got a feeling somebody's got to put their foot down. Okay, Suzanne.
I think there's been a lot of talk of adherence clubs and this patient tracing. And the question is, what is the commitment from the South African government and from the PEPFAR partners to put salaried positions in place, put them on the organogram so that there are counselors dedicated on the facility organogram in the clinic for the entire clinic working hours, and not relying on stipends that maybe get paid, maybe don't get paid, sometimes lots of different things. So if we want to prioritize the retention and the adherence role of the layperson, then I think there also needs to be revision of the staffing norms of that cadre of individual, and maybe commitments of certain levels of budget to support those activities.
I'm going to comment on that one, because this is exactly what the National Department, Treasury, PEPFAR interaction is if we can show that this works to have these adherence clubs, facilitators pay, then Treasury can make provision through some mechanism, because they can either put this stuff out for tender, or it can go on to provincial establishment, and it becomes a position that's covered by the public sector. And it's really important, because a lot of the emphasis has been to say PEPFAR partners, for example, have got 5 doctors as roving teams in a specific district. Have they been absorbed in government? And that's where a lot of the stuff has gone wrong, because normally the doctors stop roving, they get now parked in a hospital, and everybody says, gee, we've managed to transition the activity. But I think, again, it's up to us. If we think it's an intervention, we now have the go-ahead, because we're switching back into service delivery, with the PEPFAR funding is test the model, create the positions, appoint the people, document the information. Right.
Yeah, thank you. In terms of retention, somebody mentioned, the failure of the tracking device, in terms of these patients. And I'm trying to also think about patients initiated in the hospital and, referred down, to PHC level, because it seems as if TA has been introduced, and much more focused at PHC level. What does this mean, to hospitals? And, most of the hospitals are still on the PAP system, which is not feeding information to the TA. And we always often hear that the hospitals will then use PAP as a TA at a certain stage. So I think it's one challenge that we must also look at, to say how do we then pressurize or, that hospitals must be fast-tracked, into introducing the TA system so that all these patients don't get lost. And the other portion is the completeness of referral notes, from hospitals to PHC level. Because when you do capturing in facilities, that is the reality. Most of the patients' data is incomplete. Hence, it affects the signing off of certain facilities. Because hospital-referred patients, really, you don't get much, from those referrals. So, yeah, that's the point that I want to.
Thank you very much. I think it again reinforces that getting the ID number thing and getting the tier.net system up and running should become a #1 priority for all of us as PEPFAR partners. The only downside is we've all been focused now down to 27 districts, so it's not something that's happening on a national basis, but maybe we can get it in these priority districts.
Okay, thanks. It's to do with the unique identifier. I think the electronic gate system can definitely work. It works for everything else. If I don't put my MP number on a form, it doesn't matter what the specimen is. It could be a bronchial lavage in a drug-resistant patient. I really need a culture for. It gets thrown away. So the whole ethical thing, I don't understand why now it's suddenly ethical if it's an ID number. If it's something that's needed for the system, it should be there. Just because we work in the public health system doesn't mean we don't owe due diligence to paperwork. And yeah, people will learn very quickly. There are algorithms. There's no excuse not to have a unique identifier.
The importance of us doing our work at a facility level, because I sit on the NHLS board and there's an instruction from the minister that no sample can be turned down because of that administrative oversight. So it's up to us to up the game at a facility level to ensure that is included. We at the NHLS cannot turn down, it's an instruction. We may not turn down serving a patient because of a lack of an ID number.
So Suzanne has a suggestion here, then maybe we can you guys report which facilities are the ones that are not playing along? Because that would help us a lot as the partners. And the other thing, quite frankly, with all due deference to politicians, sometimes one has to go back to them and say, something needs to be rethinked. Because I do think that strategically the discussion that's been held here keeps coming back to this, that you need a unique identifier. It is cabinetly approved. Maybe it should be implemented, because I think, I can see that nowadays where you're filling in every form on a website. If they want information from you, you can argue with that website as much as you want, but you ain't progressing to the next field until you've given them whatever they want. Maybe we should be a bit tougher on some of this stuff. But Wendy, I've been contemplating whether we should, over tea time, swipe your computer and hack it and download all the data. That data has to flow from the NHLS to the partners. If you can tell us what are the indicators, which are the facilities, Our M&E, you can see how excited the M&E people become. They start jittering around on their chair. This is more stuff they can count. And they can use us to beat the implementing part of the organization over there. So,
I mean, with the Poppy Act and security, and that's a discussion for another day, there has to be some control over this as well. But if you define a proper project that involved what needed to be distributed and how, we could make that, we could do that.
So
it's not out of the realms, it's just we have to make sure, and I'll talk a little bit of security levels and different accesses to different types of data to different healthcare workers.
no, but that's not, I mean, firstly, Poppy is around personal, right? So if you don't have ID numbers, you actually don't have much personal information, let's be honest. But very simply, what we need from you is list of clinics and percentage of samples that came in with the ID number, right? That would not compromise anything on Poppy, but it gives us something to start moving on. And to say, these are the clinics we need to target, etc. Because I think it's about focusing resources. Right, so this, I think, is an important thing to move forward. Okay, back to...
I just wanted to pick up on the adherence interventions issue. I would agree that adherence clubs and managing the cadre of worker around that would be really great. But adherence clubs are for people who are adhering to treatment. And I think typically what we see is people that aren't adhering to treatment are referred to counsellors. And that cadre of workers not getting the support that they need to be able to do the work properly. So I think if 90-90-90, as far as I see, the innovations have a lot to do with a particular cadre of worker, and we should be spending a lot more time trying to invest in that. And I've seen it work really well, but that's when people get proper training, proper supervision, proper mentorship to manage issues that in other countries people need a master's degree to manage, you know? So we don't often talk about it, but I would say if we were going to incentivize anybody in the healthcare system, my money would be on that group.
So what, sorry, be specific, what do we need to do?
Well, at the moment, WOBOT teams and counsellors, we've got people from peer educators to WOBOTs to community health workers, so all sorts of levels of training and ability. We haven't properly standardized that training. That would be the first thing, get that certified as well, so that people actually have some career pathing and other things going on. But then also really these specialized skills, especially the mental health stuff, really getting that well done and well supervised for people who don't adhere. And these might be particular populations as well. It is, as Francois said, normally a crisis. So if we know what these crises are, we can address them. Is it money? Is it bereavement? Is it, SASA grants, referrals properly? Or is it adolescents that just in a time of their life they stop adhering no matter what their chronic illness is, and really honing in on how to work properly with adolescents and help them adhere to their treatment, these sorts of things. But the mental health piece is a piece that's missing in a big way. So I do think counsellors can do that work. I've seen them do that work well, but they need to be properly supervised and mentored. Does that answer you?
I think it raises an important issue that hasn't really come up, is the whole issue of mental health. I've seen stuff that says 50% of patients on treatment will have some need for mental health support. There's been some interesting stuff being done by the social scientists, at KZN, that looked at loss to follow and adherence, and found that disability is a big issue. Physical mobility, people can't get to the clinic, etc., but then also cognitive disability. So there is a big area that we don't know much about. This thing around standardized training for community health workers and career paths and stuff, this thing has been knocking around for years. There is no real consensus, and I think part of the problem is, it's a bit like the clinical associates, these physician assistants. We try to develop a generalist in 3 years that will replace a doctor, but we assist the doctor spend 7 years or plus so many years, etc. But probably the solution is to specialize them so that you have a mental health community health worker, and that's what they do. try and do all the other stuff that we want them to do. Is we start creating a specialist cadre. So I think that's an interesting idea, and we can pick up on that. I mean, FPD is willing to commit to pick up on that one and see if one could do that. Okay.
Right. So I want to pick up on this return into care issue, and I think it's something that really does seem to be a big problem, and something as a quality improvement person, I think there's very tangible kind of change ideas that we might be able to introduce to improve this process. But maybe just to kind of, I'm thinking about perhaps it's around how this person gets re-entered back into the data system. I'm not exactly sure how that works. But then it's also around the clerks and, do they know exactly what to do when they need to put somebody back into care? Is that process understood by everyone? Is there a gap there? So I guess all I'm trying to do is put out there, what is it? What does the change package look like around that issue? So it's kind of more a question than a...
So Craig, as both you and Francois has raised this issue, I actually haven't heard this often in a discussion, this return to care. So I've got a few, and there's a bit of a blank expression amongst the other tables sitting around here. So perhaps this is something at WHRI should look at, give some guidance, send something out to the rest of the people, say this is the stuff you should look at. Thanks a lot. Renelle?
Thank you. Yeah, maybe I want to be a bit more controversial because I think we're now busy unpacking all the problems in our health system. And I don't think we're actually going to reach what we've set ourselves out to do, and that is to see how we can actually assist government in reaching the 90-90-90 targets in 2 years' time. We as district support partners have been in the provinces and the district for a very long time. We haven't fixed all the problems that we're mentioning now. So I don't know how we're going to fix them in the next 2 years. So for me the question actually remains, what can we do? Because all these things about unique identifiers, there's other projects going on at the national level, they're busy addressing that, information systems, etc. So there's things in the pipeline, but we're not going to fix it as district support partners in the next 2 years. So what is it that we're going to do? How are we going to assist in terms of the second 90? How are we going to assist government? Will the government system, will the health system be able to actually manage with the additional 1.2, 1.3 million patients that need to rely on the systems? And what can we do that's innovative to actually support the health system? For example, if we want to look as district support partners to say, this is the type of support that we can provide, then let's agree on those issues. For example, the adherence clubs, yes, the comment is made that it's usually those that's adhering, that's attending those, but how can we use other methodologies to actually strengthen that, to have more of these clubs, to strengthen adherence into care? But also, what about things like franchising? How do we actually decant the patients from the health system? Because the health system have a saturation point. They can only manage X amount of patients. What about the availability of drugs? Do we have the drugs in our facilities to actually treat these number of patients? And what can we as support partners actually do to strengthen those areas? So I just want to actually just come a bit back, and I don't think we should actually get lost in the detail and about all the problems in our system. That's probably still going to be there in 2017. I'm not saying we should ignore it, but part of our normal interventions and support that we provide at facility level and at district level should be aiming at strengthening our system, but we shouldn't get lost in those. Thanks.
Thanks, Renelle. You did raise something. So a lot of it, it's always interesting, but I think there's a big difference between how some partners operate and others. So for me, a lot of the stuff you guys are saying here is thick will do, right? Do we need to, can we work on getting clinics to use the unique identifier? Absolutely, right? Because, and there's probably the USID partners, because we've got roving teams visiting those clinics. If I can get the NHLS to start telling me what the percentages are and I can track it, I can push it up. So every partner in their particular paradigm is going to have to see what they can do and how they do it. But I think Ronald touched on something which is important and that we haven't talked about. Francois had this very dramatic slide, which Mary will go back to, about your drugs being, your life being in the hands of unreliable. Okay. We haven't discussed this. Right, so I think at the moment the only partner intervention I'm aware of, apart from the sort of traditional technical assistance, trying to work with the supply chain stuff that everybody's been doing, has been this intervention that's coming from a whole bunch of civil society organizations and this call center. Because I engaged with them for the first time about a week or two ago. We had relabeled drugs where the supplier had a new sticker on it with a much later expiry date, but apparently it is quite legitimate that they can do it. But this call center kicks in and they start phoning and they give feedback. It's the most phenomenal thing. Is this the only intervention that we're suggesting, and is it one we should all be putting money in? Should we add our logos to the bottom of that thing so that they can have more people on the call center? This is open for discussion now. Unless somebody, you want to respond, Francois?
Well, maybe just give you some background to this. This was set up with funding from MSF and TAC, paradoxically, and led by the Clinician Society, which was a whole lot of people sitting in the room with a whole lot of phones who know how the system works. And every time you have a drug stock up, whatever it is, you phone them, or you email them, or you WhatsApp them, and they usually fix the problem within 12 to 24 hours. And I think it's a very useful model for how you can actually sort stuff out. And the vast majority of the problems are supply line issues. The problem with this is that because it was activist led, it became politically very uncomfortable certainly for the National Department of Health, but particularly for the provinces. The Free State actually arrested people who were perceived to be involved in this. And the minister came out screaming that we were trying to embarrass the department. I think the group have started to work with the National Department, you can confirm whether you like Peter, in a much more productive way. And in fact, like I said, we ran out of Rubian and amphotericin and Gen. They sorted it out within 12 hours. There's some things that they can't sort out. The Rubia was a national crisis because the manufacturer actually didn't make enough. But for many of the things, it is just so-and-so needed so-and-so to have it sorted out. And they give feedback. That's the critical thing. It's not just I reported and something may or may not happen. They get back to the clinician and actually do something. So I think in many ways, I think this is a really useful model for things that you can do, which are very productive and very helpful. And while the big blow up politically was maybe 18 months ago, since then people have worked very, very well together. The money, as I said, the money it cost next to nothing, and there's been no PEPFAR support to this, partly I think because it's politically been a bit of a hot potato.
Thank you very much. I think this is very important, is that we are civil society. And part of our role is to ensure that there's accountability. I know that, and I mean, you have to be, as Francois said earlier, you've got to be living under a stone if you think that we have a system whereby people in leadership positions welcome constructive criticism. But it is really important because I think if you look at the dynamics around any enterprise, the effective management and effective accountability systems is incredibly important. And this is a massive trend. What you're seeing here is this that gets lumped together under citizen democracy. It's where civil society and citizens and people start holding systems accountable. And I think I talked earlier about TripAdvisor. I don't know how many of you use TripAdvisor to look at hotels when you travel. But I can remember 10 years ago, your chances, you'd book a hotel in a place like Paris and you would end up in the most dodgiest dive under the sun. You can't find those hotels anymore, right? Just because people have been giving feedback on TripAdvisor. So again, I think it's our responsibility as civil society partners to create systems that give feedback, right? And any of you who were at the opening ceremony of the National AIDS Conferences this year probably saw how effective it is to put a few slides up about what toilets at public health facilities look like. It suddenly draws huge attention. And I think we should come up with solutions that talk towards this. So coming back to Francois has given you background. Can we leave the drug stockouts with this, or is there something that you think as partners we can do at facility level to help with drug stock? Stefan, do you want to speak to that subject?
Yeah, so at Anova we've been working with a group called Mezzanine, a subsidiary of, I don't know whether they're a subsidiary of Vodacom or they're independent. But we've been piloting this stock visibility app that enables facilities when they receive their supplies, they scan them or they manually enter them. And this system has got a cloud solution and it keeps updating the stocks. So it's a preventative approach in the sense that it tells us when we are running out of stock and we are immediately able to create buffer stocks. It's been working well, but the key to it is around robust project management, because having the app there and if it's not utilized, and I think the KZN example is one where the app is there, but it's not changing anything in terms of stock counts. So my point is around actually how, as partners, we sort of coordinate that process to ensure that the app is user-friendly, because so far it's sort of an independent, and we went into it to try and kind of fix the area that we're working in. And the reception around it has been quite good in the sense that in some facilities, 3 months down the line, we actually have them completion rate of up to 90%. So the data is becoming more and more reliable. There is, however, a second challenge in the sense that once you solve the problem downstream, which is at the facility level, and the facility is able to update its stock, there is one area that we have influence of, which is around whether National is able to help hold suppliers. We do not have a supplier management mechanism. So if the supplier doesn't supply anything at the moment, there are no penalties to that. And so what's the incentive that even if we start getting the reliable data from the facilities, the supplier are going to meet that demand? So there has to be that kind of mechanism around how our suppliers are held to account. And I think at the moment, they're taking advantage of the void in terms of information that facilities order last minute, or they don't know how to track and trace the movement of drugs in the system. So those are the two issues we could look into.
Can I just check with everybody else? Who else is working on this thing using the app? Is there any other of the partners that's involved? HST is involved, we're involved. The rest of you who are not involved, should you be involved? Cephas, can you pull them all together? Convene a meeting, little task team, all the PEPFAR partners, and get them all to pull together on this. Wouldn't it be nice if we could have they've got a television that shows you what the national power supply is. If we could have a ARV stockout meter that goes up and down. Right? And again, I think it's important because it's the type of things that hold people accountable. There's people getting big bucks to make sure that systems work and should be working. I don't think we can fix all of those things, but what we can do is have projects in place that provide better information and perhaps help hold people accountable. Okay, nice suggestion.
Well, just to add on what Cephas has said, as we are all aware, in terms of stockouts, it happens at two levels. One is at the facility level, in terms of inappropriate stock management by the facilities, and the other one is at the national level due to the supplier not supplying the drugs. The first level of inappropriate stock management, I think as partners, we can do something about that. We can support the facilities to have been trained on stock management, on supply chain principles, and also supporting them in terms of using their bin cards, whether it's the bin card as a hard copy or electronic systems in order to manage the stock system. And I think it links up with what Cephas is talking about using the app. But the big challenge, I think, is at the national level, where the supplier is not able to supply the drugs. The question is what can be done at that level so that we don't have these stock challenges that we experience from time to time. Thanks.
Thank you, Peter. So Peter, you pick up on this, but again, I've got the feeling that given the time we've got left and where we're working, we're probably at the facility. And Peter Barron will be keeping tags in terms of what can be done at national level. But I think something which is really important as partners is we've got to pull ad hoc groups together to share information. If somebody's got a cool intervention and they're using an app and they think it's working, I don't think we can say, well, we want to hoard this now. I think you need to pull the other partners in, because it's 10 organizations pretty much that cover all of the districts that are the priority districts. So it's not a large group of people to pull together. Right, so we've talked about stockouts, we've got some solutions. Those of you who want to partner with the Clinician Society, go and talk to Francois about it over lunch break. It's necessary for us to move to the next subject, and I've got no idea what the next subject is. Not the next big theme, but in terms of the stuff that Francois raised. Now, we covered all the big issues, Francois, that you had there. Mary, flip through the slides for me for a second, please. Retention and care, we've talked about that. Yes. Romy. No. You either take this, that, but stand up, otherwise the camera can't see you.
It's not really a point. One of the things that I think Francois raised in his presentation that we haven't really spoken about is accessing the key populations and how to actually get them onto treatment, and also looking at the disparities between males and females.
Okay, thanks, Romy. The floor is open for innovative. I think the key pops are, there's lots of people focusing on that, but let's talk about men. Because that seems to be the one that we all just shrug our shoulders and say, what the hell, they're going to become extinct, we don't really need them. We also work a bit in gender-based violence, and I was at the WHO gender-based violence meeting where there was only 2 men in the whole meeting, and I swear the conclusion of the meeting is, if you just exterminate men quickly, there'll be a burst of violence and then we will have tranquility. So who wants to pick up on how do we get men into treatment? Okay, so the collective wisdom is we haven't got a bloody clue. So earlier today we said that if we can get testing into places where men hang out, that might help. That was the one thing that came out of the conversation. Any other bright ideas? Jared.
I think I just wanted to...
No. If you take the microphone, you've got to come and stand here where the camera can see you. You can't take it and look at the wall.
I think because we don't have any idea about how we can get men more involved, I think we need to think about how early can we target men. And I think there's a focus now on adolescents, not just girls, but young men. And we're realizing we can't identify ways to get men because it's probably a cultural thing. And there's more reasons why men are not accessing the health facility. But we can focus a lot more on our adolescent male interventions, so at least we can start planting the seed early on men accessing the healthcare facility, and it speaks to also being a bit more adolescent friendly at our health facilities.
What do you want us to do?
Well, I think, again, starting early, we need to start to formulate adolescent programs in our health facilities, train our health facility workers on how to be more adolescent friendly, so we can actually attract young males into our facilities. The older males, I'm still thinking about that one.
Okay, it probably picks up on schoolhouse and things like that. Are you going to speak up on behalf of the men?
Only when I get a camera. So Fareed came to another meeting we were having yesterday and said that the only thing I taught him in 20 years was that all men are gay until proved otherwise. So that's the one way we can get them into the services, because we're going to have quite good MSM services, we just don't deal with straight men. I think actually was kind of responding to the last comment though, because we often hear men circumcision testing, and adolescent male services might reduce the epidemic long after we're gone, but it's not going to help the yield in the next 2 years, because the bulk of infections in men are not happening in 15-year-olds. So it's a good thing to do, but it's not the immediate thing. So if we really are trying to target men, we've got to, for the yield purposes and the new buzzwords, I think we've got to look at those 25 to 35 age group. Some of them have jobs, some of them don't have jobs. So we know that the jobs don't allow them to go to the clinics. It's a no-brainer that there should be some after-hour service or weekend service that targets men, but I think it's almost impossible to put in to provincial or state facilities short of direct service delivery. So are we going to go back to doing that? I don't know. Can we get provincial health services to make that decision? We haven't been able to yet. I think we can target the first 90 testing if we really seriously think about trying to find men at social events, but I'm not so sure about ones who actually have jobs, unless we do workplace programs or something that allows them to get treatment without spending 3 days a month waiting in a clinic queue.
There was an interesting article the other day in The Economist, and it looked at the hours that you work and your socioeconomic level. And what they're describing is an absolute inversion from what was the reality 100 years ago. 100 years ago, if you were educated and affluent, you had lots of free time. And if you were poor, you were working 100 hours a week. And it switched around. Now, if you are educated and affluent, you work 100 hours a week. And if you are poor, you're lucky if you get 40 hours of work a week. And I think the reason why it's important is that what James just has said is that men can't afford to spend days away from work. Right? So again, I think we need to be practical. What can we do as PEPFAR partners? I think we should go back into service delivery. I think we should go to some clinics and say, listen, we're willing to run a service there after hours, etc., and see if it's possible. If we can't do it there, we need to find NGOs where we can. Because otherwise, there is no other right solution at the moment of how do you get men into treatment.
I just want to share an experience we have. I'm from Orem, and this experience is from HIV prevention, but I think there's a lot that we can learn from prevention that would help care and treatment. We are running a program that tries to attract older men. And bear with me, gentlemen, but we have described our older men as older than 25. So mature men. Addressing the very thing that if you want immediacy of impact, that is the target group. So we ran a study that looked at what were the barriers to access to care for about 9 months, and input from that evaluation was then implemented in the second phase of the study, trying to put some of those interventions in place. So essentially, some of the key findings were that men do not want to be mixed up with little boys, particularly when it comes to sexual and reproductive health issues. So one of the easiest things that can be implemented and scaled up is affording men or mature men services at times that they perceive not only to be convenient for them, but confidential, private, exclusive, that sort of thing. So some of the interventions are they're not scalable, admittedly, but there are some that are. There was a point when we decided deliberately to offer services in an MMC clinic on Friday afternoons and Saturdays exclusively for men. And the uptake we saw in that, you'd expect, it was high. But this is something that can be negotiated, that can be done. We have 24-hour clinics in the department. If we just publicize, these are the hours that we offer exclusive services to men, that might work. The second thing that we picked up was trying to integrate men's health issues as opposed to HIV counseling and testing or circumcision or services that are offered in silos. So presenting a package of service that is tailored at mature men. So those two things I think are quite scalable, and it's a matter of marketing and presenting this and letting the population know that these sort of services are available.
So I like that. Can we all agree that we're going to try this? See if we can negotiate services that are available to men at hours that suit men. And that we will market it reasonably simplistic to men, because you can't be too complicated in your message to us. We don't understand. James, any possibility of taking the MSM services and expanding it to other men? Or is this one of the stupidest questions that have ever been asked?
Now, you know what the interesting thing about what the MSM service model is that they're not really dedicated clinics other than 4, which are centers of excellence. The others are a process of training up within state health facilities. They're as difficult to maintain and mentor as anything else, but we've trained about 150 clinics. Hopefully, the care that men get in those clinics will already be better. And what you do see is that men come, all men are quite happy to come there because they think they're surrounded by men. So it's a very similar thing. They think that they're surrounded by men, and the nurses aren't going to shout at them, because that's what it's all about. But I think it's the timing. I really think it's timing that's probably the most crucial thing. We see again and again in Heidi's work and everyone's work that if you provide testing facilities that men can access, they'll test. If you provide a clinic service where the nurse doesn't throw them out, they'll go there. But staffing that in the long term, I think, is going to be more difficult.
Thanks, James. And Paul, I love it when people are willing to tackle controversial political issues, like defining maturity at 25. In men. In men, yeah. Okay. Yes.
Hi, I'm Mulemo Ing, TBHIV Care in the Cape Metro. I just have some sort of a question for clarity in terms of being prevention partners. We're talking about doing the first 90, which is finding the HIV positive clients. Then we speak about linkage into care. My question being, you sometimes have a challenge as a testing partner whereby you are able to identify a positive client, you refer to the facility, but enrollment into care takes long, probably due to availability of resources. Francois spoke about having more nurses, but the issue becomes how many are NIMAR trained, who can be able to be decreasing the workload in terms of enrolling into treatment. And then secondly is the process of, as a prevention partner, where do I get to say I have linked to care? Is it when the client reaches the facility or when the client has been commenced on treatment?
I mean, in my opinion, when they've reached care, because getting them onto treatment is outside of your control, unless you're working in that facility. But I think there's some nice suggestions here. And again, it comes down to governance and management. If you are going to, you'd all agree that we believe that if a doctor is going to hang up a sign that says they're a pediatrician, that you would expect somebody's checking that they actually have the qualification. I just find it fascinating that when we get to things like NIMARD nurses, we're quite happy to ignore these rules, right? You know, all private sector doctors who dispense need to have the dispensing license. When we get to nurses dispensing, it's not necessary. Do you need to be trained to be a primary care nurse? In theory, yes, but do we check whether you've got the qualifications before you let you do some patients? We don't. So there's a big governance issue. In my opinion, you should not be prescribing the NIMARD drugs if you haven't had the training, if you're not certified to be competent, etc. But again, it's something that all we can do as partners is to help with the training, getting the portfolios in. It's an incredible schlep. I mean, we've been tracking the nurses in the facilities that we support and systematically trying to make sure everybody's accredited. The other problem is, of course, the churn. As soon as you get all the nurses accredited in the unit, they all churn out and suddenly you've got nobody left. So there's a big, I think the message for me that's come out of this is you need the management. You need the province and the district to come and say, here's the rules of the game. If you want to work as a NIMARD nurse, you've got to be trained, you've got to be accredited.